Hi, I'm Brianna, and this is Decoding Physiology, a series from Decoding TX where we focus on the physiology behind different conditions and diseases that we see in our patients, because we believe that if you understand the why behind various clinical entities, you'll learn for the long term and be able to make better decisions for your patients. This is part 3 of a multi-part series on metabolic alkalosis, so make sure you go back and watch parts 1 and 2 if you haven't already. This time we're going to talk about the next step in the process, assessing the GFR. A state of low glomerular filtration rate in chronic or acute kidney disease can lead to an alkalosis. And we're talking about a GFR of about 40 or lower in this case, so it has to be pretty significantly reduced. So just like earlier, the first step is creating the alkalosis. Two major ways can create alkalosis in CKD. One is calcium alkali syndrome, and this is formerly known as milk alkali syndrome. The physiology behind this is a bit beyond the scope of this series, but stay tuned for a future video describing the pathophysiology of this syndrome. The other big cause is the addition of bicarbonate or bicarbonate precursors to someone with a low GFR. The main ones that we see in the hospital are sodium bicarbonate, sodium acetate, sodium gluconate, and sodium citrate. All of these lead to an extra load of bicarbonate in the body. Step 2 is maintaining the alkalosis. And this is where the big issue is in kidney disease-related alkalosis. It really comes down to simple filtration dynamics. If you have a low GFR, that means that you're going to have a lower ability to filter anything in the blood. That's why we see higher levels of things like potassium and BUN in patients with CKD, and the same goes for bicarbonate. Normal kidneys can handle up to 1,000 milliequivalents of extra sodium bicarbonate per day, with pretty minimal effects on the concentration of bicarbonate in the blood. Let's use a quick example to understand this. Let's say we have a set of 2 fully functional kidneys, represented by my lovely drawing of 4 nephrons here. If we were to add 1,000 milliequivalents of bicarbonate to these 2 healthy kidneys, it would be distributed equally among all the different nephrons. They would each handle part of the load, and the kidneys would be able to handle this bicarbonate without letting it accumulate in the blood. But if we have the state of chronic kidney disease or acute kidney disease where we have a substantially lower GFR, and we add the same amount of 1,000 milliequivalents of bicarbonate, all of that extra bicarbonate is going to have to be handled by a much smaller number of functional nephrons. And those nephrons can't handle all of that by themselves. And so any extra bicarbonate is going to stay in the blood. If it accumulates over time, this leads to a clinically relevant metabolic alkalosis. Importantly, another trigger that can contribute to this is an elevated aldosterone. The physiology of why we have an elevated aldosterone and how this leads to bicarbonate will be explained later. But for now, just note that this can contribute and exacerbate the state of a metabolic alkalosis. Here are important references, same as last time. Please join us for part 4, where we'll step into the next potential cause of metabolic alkalosis.